Today we're going to be talking about fascia iliaca blocks. We're going to go from something very broad, like Lisa's talk, to something very specific. Just a roadmap for where we're going here. Sorry, there we go. Roadmap for where we're going here today. We're going to touch base on the indications, the contraindications, the anatomy, the ultrasound evaluation approach, the supplies that you're going to need, and the setup in order to do the block. And then finally, just touch quickly on the complications you should be aware of if you are going to do this. So we'll start with a case. You have an 85-year-old female with mild dementia who presents after a fall. You can't get much history from her, but you do know that there is a leg length discrepancy. The patient is unable to ambulate secondary to pain since the fall. I could just have a junior willing to shout out what they think about this X-ray. Or you can put it in the chat if you're shy.
Yeah, it looks bad.
Yeah, it is broke, yeah? All right, but for bonus, does anyone else notice anything else other than the broken femur? Well, as ortho would say, a broken hip, not broken femur. Anyone notice anything else on this X-ray? Just to make sure we're all reading our X-rays properly. For bonus points. The pubic symphysis is pretty wide here, so I'd be worried about that as well. But just a plug to always read your X-rays and make sure you're looking at everything. But yeah, so Shane hit on it, it's broke. So we should do something about that. The question then becomes, what do we do? Obviously, we need to call our orthopedic colleagues to get definitive care for the patient. But while they're sitting in our CCT, maybe we should be nice to them and help take care of their pain. Something that we often forget to do, we meaning me. So the indications for doing this block, you're looking to provide regional anesthesia to the anterolateral thigh, and it actually even extends down into the lower leg towards the medial ankle. Femur fracture is the most widely described use of this block, at least in the emergency medicine literature, but it can be used in other settings. So in the setting of a significant burn that is otherwise unable to be controlled with oral or parenteral pain medication, or other large trauma that then puts you at risk of potentially using too much local anesthetic. So here's your situations. I mean, you have grandma going hard on the bicycle and then has one of these injuries. Maybe grandpa gets a little bit too jazzed about going downstairs for a midnight snack and then falls. You maybe have somebody who comes in, spills a hot pot of boiling water on themselves or boiling oil, hot oil, and you have this big area of painful burn to the thigh. Perhaps you're going to transfer them, but maybe before you transfer them, you can give them something for pain. This one, I went on Google and just looked for a big laceration. I was looking more for something with like multiple lacerations, because the thing worth pointing out here is that on this wound, there's actually violation of the compartment, the muscular compartment of the thigh. So you're not actually probably going to want to use a regional block here. Any anesthetic you put into that compartment is probably just going to effluate out of the area. But if you do have something, maybe somebody with multiple slash wounds or something more superficial, maybe worthwhile to consider using a block to prevent them from, potentially having an overdose on the local anesthetic that you are using. That brings us just very quickly to the evidence that we're going to touch on. This was taken from both the LIEM website and the NISOR website. There's two big studies that have really looked at this specific block. So the first one was a study done in 2008, which is a retrospective chart review. They looked at basically patients who had either received the nerve block or systemic opiates. It was obviously retrospective, so not randomization. But what they did find is that the in-hospital complication rate was significantly lower for the nerve block group. And then the hospital stays were also shorter. The complications as described were confusion, risk of pneumonia, UTI, all of which were lower in the study group. In 2010, there was a lit review that looked at multiple different types of studies, so 34 randomized controls, a bunch of observational studies, and a few reviews and meta-analysis, which basically showed the same thing: decreased rates of mortality, decreased rates of confusion, and fewer respiratory complications in patients who underwent a fascia iliaca nerve block, either preoperative, postoperative, compared to parenteral or oral opiate pain medication. And then before we get into the actual block itself, the last thing to think about are a lot of the things that we think about when you're going to be putting a needle into somebody. Overlying cellulitis is obviously the biggest contraindication. You should never stick a needle through something that is infected. Sort of looks like Ukraine, but maybe that's just current events. The other thing to keep in mind is any patient, which we don't get a lot of because we don't have a big vascular surgery population, but anyone who's undergone any sort of surgery that would alter the anatomy, in this case, patients with bypass grafts, they may not be, not that they won't be eligible, but it may make your life very difficult when you're trying to identify the anatomy to perform the block. So that may be a contraindication. And then lastly, anyone who has risk of thigh compartment syndrome and may ultimately need to have fasciotomy done should not get this block, as we'll talk about. The fascia iliaca nerve block involves infusing about 30 to 60 cc's of fluid into the thigh compartment. So anyone who's already at risk of a high pressure probably should not be someone who receives this in order to not exacerbate the problem. So just to quickly touch base, this is the anatomy we're talking about here. Again, the fascia iliaca nerve block is actually a combination of blocks of two different nerves. So the femoral nerve, which comes from the anterior thigh down to the medial lower leg, and then the femoral cutaneous nerve, which if you remember from anatomy is another branch off of the sacral plexus down over here onto the lateral side of the thigh and the hip. So again, just talking about the anatomy, you're going to be placing your probe on the medial portion of the inguinal crease. So kind of about there where you see the little yellow blocks. And then you're going to move laterally. So you're going to move from basically the medial 1/3 of the thigh, medial 1/3 of the inguinal canal over to the middle 1/3, sliding laterally. For the rest of this talk, I tried to use only right-sided anatomy pictures and ultrasounds, but yeah, this can obviously also be done on the left. So as we just talked about, you're going to place your probe on the medial 1/3 of the inguinal crease, and you should see what you see here. It should be a view that's pretty familiar to most of us, especially if you've ever tried to place a femoral line under ultrasound guidance, that you see your vein medially, you see your artery next to it. And then as what's always described as sort of a honeycomb appearance in the ultrasound literature, you see the nerve, in this case, the femoral nerve. In order to get the view that you're going to want in order to do this procedure, this block, you're going to slide from the position that you're in right here, which is the medial 1/3, and then slide to the middle 1/3 of the inguinal crease. Identify these landmarks. I tried to overlay it so it sort of looks like you're sliding to the lateral side. But you go from seeing the vein, artery, nerve, now seeing the artery, the femoral nerve, and the most important thing that you're going to need for your landmark here, the iliopsoas muscle and the sartorius muscle up here. And as the arrows are indicating to you, this kind of hyperechoic or bright line here is the fascia iliaca, which is going to be what you're trying to get into as you do the block. So again, just going over the anatomy, what you want to look for are the sartorius muscle and the iliopsoas muscle on ultrasound. And you're going to be, or at least the way we're talking about it today is going to be the infrainguinal inline lateral approach, meaning coming from below the inguinal canal, performing the needle placement in line with your ultrasound probe, and coming from the lateral side of the thigh. There are many different ways that this block has been described: superinguinal, infrainguinal, inline, in plane. I will leave it up to you to look up the other ways to do this if you're so interested. So again, you'll be placing your probe here in the middle one, or the lateral 1/3, and sliding to the medial 1/3. Your needle is going to be coming in laterally, which is the direction you see the needle pointing, or the arrow pointing there. And you're going to be bathing both the femoral nerve and the lateral cutaneous nerve of the thigh with the anesthetic of your choice. So the last thing we need to talk about before we actually get into the how you perform the procedure is just talking about the supplies. So this is a little bit intimidating looking at all these things laid out, but it's actually quite straightforward. It is a sterile procedure, so as Dr. Bond would love you to do, please get a sterile probe cover and put it over the ultrasound machine. You're going to use your linear probe. you're going to need a large syringe that can be attached with a luer lock, so either 30 or 60 cc's with the appropriate connection tubing. You'll also need a 20 gauge spinal needle or something similar that can reach into the space, sterile gloves, ChlorPrep, and then whatever anesthetic you're planning on choosing. In this case, we usually either use bupivacaine because it's what we're more familiar with in the emergency department. Ropivacaine has also been described as a long-acting anesthetic. And then the other thing would be to most likely use a local anesthetic to help with patient comfort. The other thing, which is listed as optional here, but is sort of not optional, is intralipid, and we'll get into why in a little bit. But basically, if you run into risk of complication, it's good to have it handy. All right, so the last thing we'll talk about before we get into the actual thing is the anesthetic selection. In this case, the two that we're usually going to be talking about are going to be bupivacaine or ropivacaine. I did steal this from LIEM, so for anyone with OCD, this is very annoying with the E floating down here. But in any case, these are the two long-acting anesthetics. The max doses here are listed over on the right-hand side. And it's always good to keep in mind because, we are going to be infusing a large amount of anesthetic. So please make sure that you calculate what max dose is appropriate for your patient. All right. So this is what your final setup should look like. I forgot to list under the supplies, you need another person. Usually it helps so that one person can be holding the ultrasound probe and guiding the needle into place, and the other person can be controlling the syringe. So yes, bring a friend. What you have here is the normal setup. So you have a, well, this is actually sort of a fancy spinal needle. It has what you can see is like a pressure transducer coming off the side, which can help you figure out when you've popped through a certain space. In our case, in the emergency department, we'll probably only have access to a spinal needle. But in any case, you can still attach the tubing to the back end of it and have that going into the syringe. The other pointer here is to please make sure that you've primed your tubing. Please don't put like 3 to 5 cc's of air into your patient's thigh. That would be bad. Yeah. So here's what the cross-sectional anatomy would look like, courtesy of NYSORA. And please note, please put an ultrasound probe on your ultrasounds or Dr. Bond will be very mad. So what you're seeing here is, again, you have your iliacus muscle, you have your sartorius muscle, and this right here is your fascia iliaca. And then up here floating in the top part of the compartment is also the lateral femoral cutaneous nerve, which is another thing that you'll be potentially looking to hit with your block. And then, as you can see here, still missing an ultrasound probe cover. This is sort of what your approach will look like. You don't necessarily have to drape the whole patient, but it should be done sterilely. The field will be with your ultrasound with probe cover on the middle third, and then your needle coming in from the lateral side. Just very quickly, this is what the anatomy will look like on ultrasound. This is courtesy of Matt Racinti's website, the POCUS Atlas. And as you can see, you have your nerve, you have the fascia iliaca indicated here by the asterisks, and you have your iliopsoas and your sartorius muscle. What you're trying to do, again, is to get your needle into that space underneath the fascia iliaca. The described methodology for this is you introduce your needle, you should watch it in line, approaching all the way in. And once you break the skin, as with any procedure, you're applying negative pressure to make sure you don't end up accidentally in a vessel. And you advance, and once you think you're underneath the muscle, you can try to hydrodissect by asking your assistant to push in approximately 3 to 5 cc's of fluid. What you should see when you get there is an opening up of that space. So this is an actual live ultrasound, well, not live, recorded, of somebody injecting, hydrodissecting underneath the fascia iliaca. And you can see it starts to expand in that space. The one thing to keep in mind is that if you're doing this properly and you're in the right place, there should be minimal to no resistance to you infusing this fluid in. If you are hitting resistance for some reason, recheck your position, make sure that you are where you think you are. Another plug for always making sure that you see your needle tip and know exactly where you're infusing. Once you inject in, you're basically going to be putting your fluid here. So this is sort of a schematic. This is actually a different appearing approach, but for our purposes, it shows what you want to do. This is your fascia iliaca, this big white line here, which is made, I think, a little bit more large for illustrative purposes. What you're trying to do is infuse your liquid in underneath that area so that it hits the nerve that lives in that same compartment. All right. And then just very quickly, our procedure team did ask me to touch base very quickly on femoral nerve ultrasound. This is basically just a different sort of block where you're just bathing the nerve itself as opposed to the compartment. As you can see outlined here, the fascia iliaca is still viewable. You're using the exact same approach. The only difference is now you're just looking to bathe the physical nerve itself. So you bring your needle, just like you would any other nerve block under ultrasound guidance, you bring it as close as you can to that honeycomb appearing sort of structure. Please try not to stab it. And then when you think you're close enough, you can, again, use the same technique, hydrodissect with about 3 to 5 cc's of fluid. And you should see it sort of wrap around and bathe that nerve, which is illustrated here. So you see sort of that honeycomb structure there. No, well, no, hang on. I don't know why this asterisk is off. The honeycomb structure is here. And as you can see, there is fluid being injected around it. So this would be just a femoral nerve block as opposed to a fascia iliaca block. And again, this is why it's important. It just gives you anesthesia to different portions of the leg. So if you're not, really requiring anything out here to the lateral side, and maybe you're more interested just being over here on the lower medial portion of the thigh, this may be the nerve block to do instead. And then the last thing we'll talk about are just complications. So this is why the quote unquote optional intralipid was mentioned earlier in the supplies. If you kind of remember, there was an old attending who used to be here who loved to question you about what the first signs of local anesthetic toxicity are. And the answer to that question, so I won't ask anybody, is usually it's something nerve related. So perioral numbness is the most commonly described early symptom of local anesthetic systemic toxicity. And this is then followed by other neurological signs like tinnitus. It can also, involve agitation, dysarthria, and then eventually confusion. These complications usually only occur, 1, if you've used way too much anesthetic, or 2, if you've accidentally infused your anesthetic into the vascular system as opposed to the space. So again, plug to make sure that you do know exactly where you're putting your anesthetic. Eventually, if these aren't treated, it can lead to CNS depression, seizures, coma. You can also have other systemic signs in the cardiovascular system, hypertension, tachycardia, which then, since most of our anesthetics are sodium channel related, will then eventually lead to bradycardia, hypotension, and if you really aren't paying attention, eventually to ventricular arrhythmia and then asystole. So please keep that in mind. And as mentioned, the antidote for this is intralipid, which, as Dr. Berland over the weekend described, basically just creates a new compartment inside of your body where you can sequester the anesthetic. So it creates a lipid compartment that then binds the anesthetic that's floating around. Instead of it being exposed to the cells in your body, it just floats inside of a bunch of fat, which is kind of gross. But I guess if you're dying, you don't have much choice. The last complications to think about, allergic reactions. I guess it's possible if somebody has never been exposed to a local anesthetic before, they could be allergic to, again, I can't remember the 2 classes are, amines or non-amines, something like this. Esters, sorry, there you go. Esters and amines. Thank you, Dr. Silverberg. If someone is having an allergic reaction, please treat it appropriately. Use supportive care, steroids if needed, epinephrine if needed. And then lastly, an inaccurate or ineffective nerve block. If your patient is telling you that it didn't work, I guess you can believe them and perhaps move on to something else. It should be pointed out that even if you've done an inaccurate block, the amount of anesthetic that you infused into that patient should still be counted as being inside them. So do not give them more or attempt it a second time really, because you do run the risk of overdosing them on anesthetic. That brings us lastly to this quick video, which just gives you, oh my God. There we go. We'll just turn off the sound there. It's a little intense. But this just gives you a visual representation of everything we just talked about. So again, infrainguinal, you move from the medial third to the middle third. There are different ways, I just paused it, no, I didn't, of how you approach it. But eventually, this keeps going. You slide to that middle third, and then, wow, this is a lot slower without sound. Still going. All right. But this is really just to show you the ways you can move the probe for scanning purposes. Oh, I just started again. But yeah, so that's sort of the end of it. I would very quickly like to thank the procedure team for their feedback and helping me realize that this is supposed to be closer to 30 minutes as opposed to 15. Yeah, here's some references, lots of ultrasound stuff. NISORA is a great resource for these things. And yeah,